Welcome back to Pharmacology. We already went through the adrenergic drugs, so let's go through the antiadrenergic drugs. So the irreversible antagonist is going to be a non-competitive inhibitor, or antagonist, sorry, I shouldn't say inhibitor. So it's irreversible because it doesn't bind to the active site, it binds to the allosteric site. One of the examples is phenoxybenzamine. The reversible antagonists are competitive because you can flood the synapse with the substrate in order to bump off the antagonist. They use the same active site. So a non-selective reversible antagonist would be Phentolamine. The selective ones would be the selective A1 antagonist would be prozosine, terazosins, doxazosine, and tamsulosin. Tamsulosin is particularly important to us because this is used to target the A1A receptors in the prostate. And another selective but alpha-2 antagonist would be mirtazapine. Phenoxybenzamine is going to be used to decrease blood pressure or treat hypertension. It will decrease blood pressure, but it will increase the heart rate because it works on the alpha-2 receptors, or the alpha-1 and alpha-2 non-selective, and they will let's see. Yeah, so they're irreversible, so and non-competitive. So these would be the allosteric site binding, and the problem is that they can lead to the postural hypotension due to decreasing the blood pressure and the vasoconstriction. So it would be worse in a person with pheochromocytoma because you have to treat them with an alpha blocker and then a beta blocker. So you can't just use a non-selective alpha beta blocker. You can't just use it. The alpha blocker first, in order to dilate the vessels, and then the beta blocker to decrease the heart rate. Because if you do it the opposite way around, right, you're going to make the vasoconstriction worse because you're going to try and compensate for the decreased heart rate. So the adverse drug reactions would be the fainting, thanks to the postural hypotension, and the tachycardia because of the baroreceptor reflex. So loss of the predominant tone is going to increase the heart rate to try to compensate. So phentolamine is going to be similar, but it's reversible. And you use it with the epinephrine to decrease a fall in blood pressure only. So it's not really used to increase contractility. It's not going to really be used to it's not going to be used as a it's going to be used as a vasomotor reversal of DALE. So the alpha blocker, remember to block the first half of the biphasic response and let only the beta response occur. So beta blocker and epinephrine is going to be used to raise the BP. So it's going to be the vasomotor reversal of DALE. So in phentolamine, it's non-selective. It's going to help with the it's going to start the baroreflexor reflex, increase the sympathetic tone, so heart rate's going to increase. But using the alpha blocker, it's going to decrease the blood pressure. But we always have to remember that there's going to be that reflex tachycardia. So we don't want a reflex tachycardia. What do? We use A1 selective blockers, so prozosine, terazosine, tamsulosin. So they're used to decrease the blood pressure, except for tamsulosin, remember, but they do result in tachycardia. Tamsulosin is going to be used to treat benign prostatic hyperplasia, and the rest is going to be used to treat hypertension, renal phenomenon, and congestive heart failure. So all of this they use because these are going to be venodilators. The adverse drug reactions would be drowsiness, nausea, headaches, and the first dose phenomenon is going to be the postural hypotension. The postural hypertension occurs because the dosage is actually like self-limiting. It's not too bad, but it has to be initiated at a low dose. So let's go back a slide. So here, prozosine. It's going to be alpha-1 selective. It's going to work on the peripheral vasculature. So it's going to decrease the blood pressure, but there's no like blockage of the alpha-2 feedback. So with the baroreceptor reflex, there's not going to be as high as in phentolamine because it's not alpha-1 or alpha-2 selective. It's only alpha-1 selective. So since the alpha-2 receptors are like not blocked, the negative feedback occurs. So there's not going to be any tachycardia. And this one, like, of course, it is also used to decrease the tachycardia. So with the tachycardia not being present, there's no way for the blood pressure to compensate. The heart's not beating any faster, right? So there's less perfusion to the brain. Person gets like postural hypotension. It's okay though, because this is something that the body can get used to. It just takes time and some like training. Like you can't just sit up very quickly. You have to sit up and stand up in stages. So in benign prostatic hyperplasia, it's in elderly males. You want to give them first an alpha-1 blocker, so one of these, particularly tamsulosin, and a 5-alpha reductase inhibitor to relax the prostate. So the alpha-1 blockers to relax the prostate, and the 5A reductase inhibitor is going to shrink the prostate. Mirtazapine is going to be a selective alpha-2 blocker, and it's an antidepressant. So it's going to increase the amount of norepinephrine and serotonin released. The beta-adrenergic blocking agent, remember they all end in olo, so A through M is going to be a selective beta blocker, so the important one you need to remember is carvedilol. N to Z is going to be the non-selective beta blocker. Important one to remember is propranolol. So there's no intrinsic sympathomimetic activity. Okay, so it's not going to mimic the sympathetic, intrinsic sympathetic nervous system action. These are the ones, propranolol, timolol, and sotalol. But the ones that do actually mimic the sympathetic action is going to be pindolol. The non-selective, or not the non-selective, the alpha and beta blocker agents would be carvedilol and labetalol. And the cardioselective ones would be the beta 1 selective. So these usually end from A to M. Okay, so propranolol is going to work on both the beta and the alpha-2 receptors. So in the heart, it's going to decrease the cardiac output, and by doing that, it's going to decrease the blood pressure, and importantly, it's going to decrease oxygen consumption. So with less oxygen demand, there's going to be lowered heart rate, lowered contractility, lowered action potential, or like firing. So in the vessels, it's going to inhibit the beta 2 receptors for vasodilation. So of course, these are going to be contraindicated in people with peripheral vascular diseases, such as Raynaud's. bronchoconstriction, it's going to oppose the beta 2 mediated bronchodilation. This is going to be contraindicated in COPD and bronchoasthma. Of course, because you want the patient to breathe. In the kidney, propranolol will decrease the renin release because it decreases the blood pressure. So without the blood pressure, it's the symbol to stop renin, because renin will be converted to angiotensin. Angiotensin will be converted into angiotensin 2, etc., and it's going to raise the blood pressure. Propanol also works to decrease glycogenolysis and the decrease in glucagon. So this is bad in pre-diabetic patients because it can decrease the insulin release, which is, what they need. So we have to monitor these patients pretty carefully. And in the muscle, unfortunately, this can increase anxiety-related tremors. In the CNS, it can result in nightmares or hallucinations. Propranolol is used to treat performance anxiety because it inhibits the sympathetic overactivity. In the eyes, it will decrease the secretion of aqueous humor, and by doing that, it will decrease the intraocular pressure. So timolol is used to do that. And it treats glaucoma, but it's contraindicated if the patient has asthma. So the alpha and beta blockers can interact quite severely with ditch or digoxin and verapamil. That can lead to the cardiac arrest because there's the tachycardia from the alpha-1 blockers and the hypotension, and there's just it's just a bad mix. With insulin and hypoglycemics, it's going to increase the hypoglycemia. With the NSAIDs, it can result in resistant hypertension because the prostaglandins are going to be inhibited and the veins are going to constrict. And then with the alpha blockers, they're going to inhibit the venodilation. It's going to work with the constriction and making all the hypertension worse. Hypertension used to treat, you use atenolol to treat hypertension, timolol to treat glaucoma and performance anxiety, and in migraines, propranolol is a prophylaxis. Hyperthyroidism is going to be used using propranolol and esmolol, and classical angina or angina pectoris, myocardial infarctions, cardiac arrhythmias. CHF in stabilized patients only, so these beta blockers are going to be very useful. Okay, so these are the adverse drug reactions. The ones we need to be worried about is the bronchoconstriction and the rebound hypertension and an increase in myocardial infarction risk. Contraindications, once again, in COPD, bronchoasthma, because the beta blockers would increase the constriction of the veins. Diabetes, it decreases insulin secretion. Partial heart blocks, too much beta blockers, too many alpha blockers can cause atrial fibrillation or arrhythmias. Variant angina or Prinzmetal angina, it's spasms of the heart due to faulty conduction. These will not help the conduction. Severe heart failure, this is not also going to be very useful. You don't want to give them to anybody with peripheral vascular diseases because of the constricting effects. The beta-1 cardioselective antagonist, atenolol, is important to remember. Metoprolol, esmolol, going to not only decrease the blood pressure, but it's also going to increase the exercise tolerance. So it has little effects on the airway because it's selective, right? So it's not going to affect the lungs and the peripheral resistance too much. It's going to leave carbohydrate metabolism alone, so the patient is going to be able to actually have energy to work out. It's going to be used to treat the hypertension along with classical angina and cardiac arrhythmias and myocardial infarctions. Esmolol is going to be used in emergencies to treat the supraventricular tachycardia and thyrotoxicosis. Thyrotoxicosis can degenerate into a thyroid storm, and that's like a hypertensive emergency. Chronic use, unfortunately, the body gets used to it, and there's going to be receptor upregulation. Glucagon is given to reverse an overdose of beta-1 antagonist because it causes the chronotropic and ionotropic effects, and it doesn't work through the beta-1 receptors, it works through different receptors. So, kind of like in this way, ATP is converted to CAMP. CAMP is going to increase the calcium available and increase like the contractility and the rate of contraction. Glaucoma. So you need to give the lipid-soluble drugs so they can penetrate the cornea. In open-angle glaucoma, that means the angle is bigger than, I want to say like 45 degrees. You use medication to decrease the amount of aqueous humor produced. So you want to treat that pupillary block by causing the mydriasis. In narrow-angle glaucoma, you're going to need surgery to drain. It's going to, like, both surgery and the drugs is basically to increase the outflow of the aqueous humor and decrease the formation. So you can decrease the formation using the beta blocker and increase the flow using a drain or cholinergic drugs. Beta blocker, timolol, once again, is given to decrease the aqueous humor, and it blocks the beta-2 receptors. Prostaglandins, or latanoprost, will decrease the intraocular tension by increasing the outflow. Cholinergic drugs, pilocarpine, pheostigmine, this is important, pheostigmine, remember, treats myasthenia gravis, is given to increase the outflow, and by doing that, decrease the tension. And it also realigns the muscle around the Schlemm's canal. A non-selective alpha agonist, dipivirine, is going to decrease the aqueous humor and increase the uval scleral outflow, so also decreases the intraocular tension. However, it's contraindicated in acute onset glaucoma. Okay, so selective alpha-2 agonists, aproclonidine and brimonidine, is going to be decreasing formation by alpha-2 action. Diuretics are going to work kind of like sort of the same way, decrease the aqueous humor. Mannitol acetazolamide is also used to treat, but it is particularly useful because this treats acute glaucoma. Atropine and phenylephrine is going to be contraindicated in glaucoma. We don't want to make it worse because it's going to increase the tension by like contraction of the ciliary muscles. That's it for now. Thank you for your attention and good luck studying.